In 2018, the treatments are 5-FU-based therapies, that being FOLFIRINOX, or gemcitabine-based therapies, that being gemcitabine combined with nab-paclitaxel. What we've learned is that these two regimens were studied in different contexts. The trials are different, the patient selection was different, and the outcomes are different. But when we try to level the playing field, we do understand the treatments are probably the same, understanding different toxicities, different logistical issues, and so we have to decide what's best for this patient. When we talk about first-line therapy, we're now starting to think about second-line therapy as part of that strategy, what we call sequencing, something that we had not had in pancreas cancer several years ago. We think about using a gem-based therapy followed by a 5-FU-based therapy, and now we do have treatments that allow us to sequence, and I think more and more we're seeing that approach. So this patient was treated with gemcitabine nab-paclitaxel, and they benefited. They were given the standard regimen of day 1, 8-15 of a 28-day cycle. They did encounter grade 3 neutropenia, which was seen in about 38% of patients in the what they call MPACT trial. They did not require any growth factors. What happens when you give Abraxane, nab-paclitaxel chemotherapy is that about 4 to 5 months you develop cumulative grade 3 neuropathy, roughly 17% of patients. And so that can be a treatment-limiting toxicity. And the way to manage that is to actually hold the nab-paclitaxel. If you hold it for up to 1 month, roughly almost 50% of patients can then restart the medication as the neuropathy declines down to a grade 1 level. So it's very unique, and then you can restart the combination and hopefully garner benefit for as long as possible. Now our patient did develop progression. The chemotherapy was no longer effective, and so we need to think about second-line therapy. As we discussed, there is a FDA-approved NCCN Category 1 treatment called NALIRI, which is nanoparticle liposomal irinotecan injection. It is combined with continuous infusion 5-FU and leucovorin, and this has shown a survival benefit in patients that are gemcitabine refractory. So the natural progression in our treatment strategy would be to have the patient treated with this regimen that does show a survival benefit and is FDA approved. The side effects with this regimen, importantly, are not the same side effects that one might encounter with the first-line nab-paclitaxel therapy. In particular, there is no neuropathy seen, and there is only a low amount of thrombocytopenia. So it makes sense to kind of rest the nerves, rest the bone marrow, and move on to the second-line therapy, which provides the survival benefit. And so that's what sequencing is in 2018. Had we chosen FOLFIRINOX as our first-line therapy, again, the neuropathy with the oxaliplatin, we would have dropped that. We would have maintained the patient on the other medications, the irinotecan, the 5-FU leucovorin. The patient ultimately would experience disease progression, and then we're left with the difficult decision of what do we give the patient in this second-line setting. Obviously, it's going to be a gem-based therapy. Would it be gem, nab-paclitaxel? Unfortunately, they've encountered oxaliplatin neuropathy. Now they're going to encounter nab-paclitaxel neuropathy, so it becomes more and more difficult to progress in that, proceed in that sequence. So that's why I think this first scenario that we described, using the gem-based nab-paclitaxel, followed by the 5-FU-based NALIRI 5-FU sequence, is becoming more and more accepted in practice.